We'll start Saturday.
Hardly 2 minutes.
Yeah, we are already live in YouTube. Rohan, you can share the YouTube link to the group. 2 minutes left. We'll start exactly at 8 o'clock.
Yeah, I listen.
Sunday I will TP button.
Good evening, everyone. We are going to start our third session of NEBOY Classroom. I welcome President NEBOY, Professor Bires Kumar Das, to start his inaugural speech.
Good evening, everybody. This is our first endeavor to start this classroom academic session from the Northeastern branch of ENT and Head. Very importantly, what I like to show and do that we should be well exposed to the nation. Later, we have started this academic program and it will benefit to all, not only students, but also all faculty, because we have to fresh up all knowledge about this subject related to it. So I welcome Professor Osal Gulati to this event. At the same time, I welcome all who has participated in this academic program. Thank you. Thank you very much.
Now I request Secretary NEBOY, Dr. Anjan Kumar Fuya, to introduce our inaugurator, Professor Achal Gulati, sir.
Hello, very good evening to everyone, all the NEBOY members who have joined here, and lot have joined in the YouTube channel. Uh, it's our proud privilege that Dr. Asal Gulati, who is one of the most eminent national figure in our country, is with us today. So we invited him for the inauguration for this 2025 NEBOY classroom. So here I would like to introduce Dr. Asal Gulati sir. He is the Vice Chancellor of and Professor of Excellence at Mahatma Gandhi University of Medical Science and Technology in Jaipur. He is the former President of Ethics and Medical Registration Board and the Medical Assessment and Rating Board of the National Medical Commission and former Additional Director General Health Service of Government of India. A graduate of the University of Delhi, Dr. Gulati trained as an otolaryngologist and head and neck surgeon at PGI Chandigarh. He has completed management and administration certificate courses from IIM Ahmedabad. Over 40 years of academic leadership experience, Dr. Gulati has worked at Maulana Azad Medical College, Govind Ballabh Pant Institute of Postgraduate Medical Education and Research, and Dr. BSA Medical College and Hospital, New Delhi. Dr. Gulati is a fellow of the National Academy of Medical Science, Indian Academy of Otolaryngology and Head and Neck Surgery, and International Medical Science Academy. He has received numerous awards, including GAPIO Award of Surgical Excellence and Dr. Sarvapalli Radhakrishnan National Award and Lifetime Achievement Award. He has authored around 95 peer-reviewed publications, contributed chapters to the textbooks, and developed CDs on examination techniques. Dr. Gulati is also a visiting professor of ENT at the University of Padua, Italy, and Mayo's Clinic, USA. Currently, Dr. Gulati serves as the Vice President of International Rhinology Society, President of Indian Society of Rhinoplasty, and President of AOI Delhi State Branch. This is a short introduction of Dr. Gulati. I think I need to speak a lot about Dr. Gulati if I have time. Uh, Now I request Dr. Gulati sir to unmute himself and give his inaugural speech. Please welcome, sir.
Thank you so much. Am I audible?
Yeah.
Yes.
Yeah,
Yes,
yeah,
sir.
very much.
Yes.
So I thank the Northeast branch for letting me be over here and start this program, which is there, is taking education to the doorstep. There's a very old saying that you can take the horse to the pond, but you can't make it drink the water. But I think Biraj Das and the entire team of Northeast branch of AOI have not only taken the horse to the pond, but they've also brought the water into the mouth of the horse over here. And that is what is very important in today's time. I think this generation today has seen so many ups and downs, right from the time when the textbook learning was there, to maybe the floppy disk, to the CDs, to the computers, and now coming into the COVID era when everyone became computer savvy on video conferencing and all these new computer gadgets. Now the time of artificial intelligence has come into the whole picture, machine learning. So being up to date is not a very simple thing. It's an expensive thing, as it was in the past when we had to go to the various places to learn. But today we get those places to teach us and come to our own doorstep in our house at 8 p.m. in the evening, when otherwise routine of the time we were just doing nothing but eating and partying. But now at 8 o'clock we are also learning over here. So I think it's a very good move on the part of Northeast Branch to make this YouTube channel and bring the education at the doorstep of individuals. The topic for today is something I think which every otologist, every ENT surgeon must be aware of. It is something like temporal bone. Temporal bone is one bone which has preserved our entity. Thyroid, ENT, general surgeon, head and neck surgeon, anybody. Neurosurgery, ophthalmology, everybody is intriguing into each other's field. But temporal bone is one bone which has kept our entity, which is very important. Nobody dares inside because it houses the facial nerve. And it is one of the complex bones, with hairs, with nerves, with muscles, with so many functions and the physical functions which are there. So all these things have helped temporal bone preserve, being the preserve solely of an ENT surgeon so far. And the knowledge of this temporal bone is so important for everybody that without it, you can never be an otologist. Temporal bone is an enemy if you don't know it. But believe me, it's a friend, and it's like nobody's friend if you know it inside out. And that is what the intention of today's first class or this classroom session of the Northeast branch, which is there. Let me tell you, the National Medical Commission today has said that we need to bring in nationwide classroom. And I think this is one of the first steps what Northeast branch has taken to bring the nationwide, Northeast-wise, state-wise classroom into everybody's home. And I wish this endeavor a big success. And I'm sure it is going to be a big hit amongst everybody. God bless you all. Happy learning, happy listening. Thank you so much.
Thank you, sir. Thank you for your kind words. Thank you for joining us. May I request our chairman, uh, Professor Swagata Khanna. Welcome, ma'am. And I request you kindly to introduce our speakers as well as chairpersons, moderators.
Thank you very much, Dr. Anjana. And I welcome everyone to this academic session. And thank you very much, Dr. Gulati sir, for being the inaugurator of our Naboy classroom. I am very much happy that today's speaker is Dr. Hanifa Akhtar, a brilliant student of Guwahati Medical College. And she worked in Northeast Indira Gandhi Regional Institute of Health and Medical Science as a research scientist under ICMR. Also, she worked as an assistant professor of ENT and head and neck surgery. Presently, she is an associated professor of ENT and head and neck surgery at AIMS at Guwahati. I would like to introduce our chairperson, Dr. S.N. Mukherjee, who is a very senior person, and he did his MS from AIMS, New Delhi in 1978. He was the former medical director of Northeast Frontier Railway Maligaon, Guwahati, also former senior ENT surgeons and faculty of DNB for 23 years at Railway Central Hospital, presently working as a faculty and DNB of DNB and senior consultant at Department of ENT and Head and Neck Surgery at Downtown Hospital, Guwahati. The another our learned chairperson is Dr. Rupam Borgohain. He is presently the professor and head of the Department of ENT and Head and Neck Surgery at Tezpur Medical College, Tezpur, Assam. And he is trained in cochlear implant. I am very happy that he is taking part today's temporal surgical anatomy of the temporal bone, because I saw him in the temporal bone lab many times while I was in medical college. He was trained under Padma Shri Professor Mohan Kameshwaran and started his career with cochlear implant at Guwahati Medical College in the year 2014. Without taking much time, now I invite both the chairperson to start the session. Thank you very much. I request both the chairperson kindly take over.
Thank you, Swagata, for the nice introduction. I think we straightway go to the subject proper, that is Hanifa to present on the surgical anatomy as well as the CT temporal bone. Hanifa.
Thank you, sir. Good evening to one and all. For today's session, I'll be sharing. Good evening to one and all, and thank you for giving me this opportunity. The topic for today's presentation is surgical anatomy and CT scan of the temporal bone. So, as we all are surgeons, so what I have tried to do with my slide and presentation is that to club the surgical anatomy and the CT together, so that it becomes a little bit easier or for the PG students who have joined, so that they get an overview how to correlate the radiology with the surgical aspect. So that because CT scan is an excellent radiological tool which helps us to give us the bony details, not only the bony details, but also the interface between the bone and the soft tissue, the air and the bone. So as rightly said by Gulati sir, temporal bone is the heart of the ENT, and it is a very complex structure. So without further ado, I would like to go through. To begin with, the temporal bone, it is made up of 5 bony structures. Let me just revise. So temporal bone, it is made up of 5 bony structures. The 5 parts are the squamous part. This is the mastoid part, the petrous part, this is the petrous part, the tympanic part. The tympanic part, it contributes to the floor, anterior and the posterior part of the external bony part of the external auditory canal. The elongated process, that is the styloid process. So where the temporal bone, it has many faces of surgical importance. This is the superior face of the temporal bone. We can see that this superior face, it forms the floor of the middle cranial fossa. This is the posterior face of the temporal bone of the petrous part, where we can see the internal acoustic meatus, and this forms the anterior limit of the posterior cranial fossa. Then we have the lateral face of the temporal bone, which forms the lateral part of the head, and the anteroinferior part, which harbors the important vascular structures like the jugular bulb and the carotid artery, and it contributes to the formation of the infratemporal fossa. So we'll run through the anatomy in a quick while. So the first part is the squamous part. So this is the dry bone of the temporal bone right side, where we can see this is the squamous part, the flat part, and it can be seen nicely in the coronal view. So when before we start reading the CT scan, we have to understand that the CT scan of the temporal bone should be read very thoroughly, and it should be in a systematic manner. Like when we are reading the axial sections, it has to be from cranial to caudal or caudal to cranial, but it has to be studied in a systematic manner. not only the axial sections, we have to read the coronal sections also. So this is the squamous part in the coronal section. Then second part is the petrous part. So we can see here, this is the petrous bone, pyramid shaped bone. And in the CT scan, we can see that this is a pyramid triangular shape of the bone in the axial section. Now, coming to the mastoid part, most of us from our PG days, we have been exposed to the cortical mastectomies, mastodectomies, and now it is a gateway to the different surgeries. So mastoid, when we are evaluating the mastoid, there are a few key points we should always keep in mind. The first is when we look at the mastoid of the CT, we have to know what is the pneumatization of the mastoid, whether it is a well pneumatized, it is hypopneumatized, and we have to look at these bony trabeculae. These are the different mastoid air cells. We have to see whether there is any demineralization of the bony septas or not. We have to again see the boundaries of the lateral mastoid bone. Then this is the sigmoid plate, which we have to pay attention. And then we look into the integrity of the facial nerve also. So and lastly, the contents. If the content is air, if the mastoid is containing air, it will appear black in color. If it contains some fluid or some soft tissue, it will appear grayish in color. So if we comment on this mastoid, this is a well pneumatized mastoid bilaterally. So whenever we are evaluating any structure in the CT, we always have to compare with the opposite side. Even if the disease is on the one side, even suppose if it is looking like low-lying dura, to compare that, we always have to compare with the other side of the same patient. Then coming to the mastoid, how it appears in the coronal view. In the coronal view, whenever we are planning for mastodectomies and all, we have to look at the roof of the mastoid. So in the coronal view, we can comment on whether there is a low-lying dura which may be encountered during the surgeries, or there is any breach in the dura due to the cholesteatomas. And we also need to take a look into the vertical segment of the facial nerve while looking into the mastoid bone. Coming to the petrous part, the petrous bone, it is lodged between the sphenoid bone anteriorly and the occipital bone posteriorly. And this is the area of the posterior cranial fossa. This is the area of the middle cranial fossa. So the superior surface is basically, it is giving us the floor of the middle cranial fossa. And the petrous bone, if you see that this is the internal acoustic meatus. This is the cranial, this opens into the cranial cavity through which the nerve of our ENT importance, like 7th and the 8th cranial nerve, they passes through. We'll go into the details subsequently. So at the top of the superior surface lies the superior petrosal sinus. So whenever we start reading the CT scans cranially to caudally, for the first thing which appears is the superior petrosal sinus, and next this petrous bone, we all know that it contains the cochlea and the semicircular canal. And the first semicircular canal to appear in the axial section, it is the superior semicircular canal, which forms an elevation in the petrous bone that is known as the arcuate eminence. Now, if we see the cadaveric dissection, this shows the orientation of the semicircular canal in the petrous bone. So this is the superior semicircular canal, this is the lateral semicircular canal, and this is the posterior semicircular canal. And we can see the ossicles in the epitympanum. This is the malleus, this is the head of the malleus, this is the body of the incus, long process, short process of the incus, and this is the facial nerve, and partially the pars tensa is seen here. So in the petrous bone, it is the structure which houses the cochlea and the semicircular canal. We need to study in details these structures along with the other important structures like facial nerve, vestibular aqueduct, and all. So another bone which is the part of the temporal bone, it is the tympanic bone, which contributes to the floor of the external auditory canal, the anterior and the posterior wall. This bone is dehiscent in the upper part of that is called as the notch of the ravenous. So whenever there is any disease involving the external auditory canal, or we are suspecting any mass lesions, we always have to see this tympanic bone. In relation to the tympanic bone, we have to always also take into account these two vascular structures. This is the jugular fossa and this is the internal carotid artery, because these structures will be encountered if we are planning to operate the patient. Sometimes in the jugular fossa, we have to look for whether it is a high Reading jugular bulb. Sometimes there may be a high Reading jugular bulb with the intact bone. Sometimes the bone may be dehiscent, and sometimes it may be just a diverticulum. Now coming to the middle ear, just like the mastoid ear cell system, in the middle ear there are multiple structures. There are bones, there are muscles, there are nerves, there are windows, and there are walls. So this middle ear is divided into three parts. Epitympanum. The epitympanum, the surgical landmark, is from the tegmen tympani to the scutum. So this is the coronal section showing the lateral epitympanic wall, which is also known as the scutum. So this area is the epitympanum. This is the mesotympanum from the scutum to the bony annulus, and the hypotympanum is from the annulus to the middle ear floor. So if there is any disease, cholesteatoma, involving the epitympanum or mesotympanum, the contents like the bone, the nerves, they are liable to injury or get involved. So the superior most middle ear space or the subdivision is the epitympanum. So when we are looking into the axial sections, so this is the view of the epitympanum. So we have seen that in the epitympanum, we have the head of the malleus and the body of the incus. And this ice cream cone appearance of the ossicles, it comes into view in the epitympanum. The epitympanum, again, it has two, we can say the subdivisions, anterior epitympanum and the lateral epitympanum, by a vertical bone, which is the cog. And this cog, surgically, it has the importance that it points towards the facial nerve. And this is the adductus ad antrum, and this is the mastoid antrum. So if we see the CT scan of the patient, here we can see that this is forming a figure of 8. It is a well-pneumatized mastoid ear cell system. There is no disease, but we can see a septum here. This is the Koyner's septum, and we can see the glimpse of the internal auditory meatus. This is the cochlea, and this is the vestibule. So this is the typical ice cream cone appearance of the ossicles. So this is how, when we are doing after doing the initial cortical mastoidectomies, the sigmoid sinus, this is the posterior. This is the sigmoid sinus, and this is a glimpse of the epitympanum where we can see the incus is coming into view. In the epitympanum, we can see the frank, there is a space between the malleus head and the body of the incus. This has the ice cream cone appearance, and this is the tympanic segment of the facial nerve. So the importance of the Koyner's septum is that sometimes, as a novice surgeon, when we start doing the mastoidectomies, finding if we are not reading the CT scan, if we are not aware of the Koyner's septum, then this will appear as the medial wall of the mastoidectomies. In the epitympanum, another important structure of surgical importance is the inquidal fossa. So this inquidal fossa, this is the location of the inquidal fossa, which is a recess which houses the short process of the incus. So we can see very nicely that this is the short process of the incus. This is the lateral semicircular canal. Both these structures, the lateral semicircular canal and the short process of incus, these are the surgical landmarks to find out the second genu of the facial nerve. In the CT scan, we can correlate very nicely that this is the inquidal fossa, which is the surgical landmark. Then in the epitympanum, there is one space where the cholesteatoma may be present, especially in cases of, at the beginning of the pars flaccida cholesteatoma, the space lateral to the head of the malleus. This is called the Prusak space. So in this is a normal there is in this image, we can see there is a no disease, but here we can see a soft tissue density. So when there is a soft tissue density, we have to comment whether there is a blunting of the scutum or not. In this is an early disease and there is not much blunting of the scutum. So this is a close-up view of the structures showing the orientation of the three semicircular canals. Again, the one thing is that this is the superior semicircular canal. This is the lateral semicircular canal. So when we are dealing with the disease of the epitympanum, if there is a cholesteatoma here, we have seen in the previous slide that this is the malleus head and the body of the incus. So we encounter these two ossicles in the epitympanum. So if there is any cholesteatoma here, when we are removing the disease from the medial wall, we have to be extremely careful because anteriorly lies the geniculate ganglion, and one more structure we have to be very careful while drilling is the ampulla of the lateral semicircular canal and ampulla of the superior semicircular canal. These two ampullas, these are along the medial wall of the epitympanum, and they are not very much resistant to the drilling, so they are prone to injury. And similarly, anteriorly, the geniculate ganglion is at risk while drilling. Then coming to the mesotympanum, which ranges from the scutum to the lower margin of the annulus. This mesotympanum is a full house structure. It is full of different kinds of structures and recesses. It has ossicles and muscles. We all know the ossicles are the malleus, incus, and stapes. But in the mesotympanum, we get only the manubrium of the malleus, the long process of the incus, and the stapes crura. The head of the malleus and the body of the incus lies in the epitympanum. So when we are going through the axial sections, when we are in the mesotympanum, we will these two ossicles, they appear like dot. And here we can see that this is a stapes which is overlying the stapes foot plate. Then we have again two important recesses. Now, once we go through the images, this is the mesotympanum oval window, and once we are going a little bit caudally, we'll be able to visualize the round window. So this is the basal turn of the cochlea. This is the round window niche, and at this area we can see only the handle of the malleus. So this is the oval window and this is the round window. So in the mesotympanum, we get oval window, round window, and promontory. The promontory is formed by the basal turn of the cochlea. So this is the promontory in the axial view, and this is the promontory in the coronal section. Now in the these are the structures of the medial wall. Then in the posterior wall, we have two important recesses where the cholesteatoma is likely to be left if it is not taken care, because it is a very hidden area. So these two recesses are the sinus tympani and the facial recess. So the sinus tympani, it is the recess which is medial to the facial nerve, and the facial recess is lateral to it. So the horizontal segment of the facial nerve, after it becomes vertical, so this is the vertical segment of the facial nerve, and this recess, it appears like a W shape. So this is the sinus tympani area, and this is the facial recess. So before doing the surgery, we need to plan very nicely. So this is the close-up view where you can see this is the 7th nerve, sinus tympani. And then, as told, the facial recess, it is a gateway towards the round window for the cochlear implant surgeries. So radiologically also, we can assess preoperatively how we are going to encounter the round window, whether it is a too much curved, rotated cochlea or not, how good will be or how easy will be the insertion. This we can find out by drawing a line along the round window and the second line going along the facial nerve. And this is the approach, facial recess. So the surgeon is looking from this area. So this is a very favorable round window. Sometimes there can be a round window niche. The bone needs to be drilled, and we can in the DICOM, we can also measure the facial recess width. That one I'll be showing after the end of the presentation. So here we can see this is the for the posterior tympanotomy for the cochlear implant surgery, where we can see this is the round window. And one must remember that the orientation of the oval window and the orientation of the round window is not in the same plane. So it is a bit, we can see it is a little bit hidden, the round window. Now is the hypotympanum. So any disease or involving the hypotympanum, or when we are planning other surgeries also, we need to pay special attention to these vascular structures, the jugular fossa and the carotid. Because if there is a high riding jugular bulb, then it may create problem while doing the middle ear surgeries or while doing the cochlear implantation. So these are the structures which should be taken care. Coming to the ossicles, we know that the ossicles have to be viewed both in the axial and the coronal sections, right from the epitympanum to the mesotympanum. So this is the epitympanum view of the ossicle, and these are the mesotympanum view of the ossicles. We can see the two dots and the stapes. So if we are getting a patient coming with the conductive hearing loss, with the no history of trauma and all, of course, if there is a history of trauma, then we have to look for the fracture sites and all, or we have to see for any ossicular discontinuity. But if there is no history of trauma and the patient is having conductive hearing loss, we have to study these ossicles nicely. One thing to be noted is that the bony labyrinth, it is a dense bone. So in cases of early otosclerosis, it will be replaced by the spongy bone. It will not be as bright as this one. So, and second thing, if there is a conductive hearing loss in cases of otosclerosis, to predict any problems during the surgeries, we also have to look for the persistent stapedial artery, and which we can predict by we have to look at two important things to predict the persistent stapedial artery. We have to examine the thickness of the facial nerve and the absent foramen spinosum. So this is the ossicle, how it looks as we are coming from cranial to caudal, and now we are in the lower part in the round window area. So the ossicles, the change in shape. Then the middle ear muscles. In the middle ear muscles, here this is the canal for the tensor tympani, and this is the pyramidal muscles through which arises the stapedius muscle. When we are doing the study of the CT scan, we have to study the internal acoustic meatus, especially before undergoing any cochlear implant surgeries, because we can know about the orientations of the 7th and the 8th cranial nerves. So this is the dry bone showing the internal acoustic meatus from the cranial side. This is the horizontal crest. This is anterior. This is posterior, superior, and inferior. Anterosuperiorly lies the facial nerve, and posterior superiorly lies the superior vestibular nerve. Antero-inferiorly lies the cochlear nerve, and posterior-inferiorly lies the inferior vestibular nerve. So the importance of knowing this is that, so we are going to encounter in the superior cusp the facial nerve first, antero-superiorly, and posterior-superiorly, this is the superior vestibular nerve. Then in the internal auditory canal, as we go down, when the cochlear middle turn and the basal turn comes into view, this is the cochlear aperture, and this is for the cochlear nerve, and this is the vestibule, and this is the canal for the inferior vestibular nerve. And we can also see that this is the tympanic part of the facial nerve. So whenever we are doing any surgeries for whether it is a cholecystoma or any surgeries involving the temporal bone, we need to delineate the complete route of the facial nerve right from the labyrinthine segment to the stylomastoid foramen. That we can do by studying the axial sections from cranial to caudal and also the coronal sections. So this is the labyrinthine segment of the facial nerve. So this is the fundus. So one thing to be noted here is that the fundus of the internal acoustic meatus lies very close to the vestibule. So this relation is very much important because after we do the mastectomies, the important landmark or the bulge which is seen medial to the antrum, it is the lateral semicircular canal. And the lateral semicircular canals, and if while planning the cases for removal of the CP angle tumors, translabyrinthine approach, when these semicircular canals has to be labyrinthectomy has to be done, the medial wall of the vestibule, it should be noted that the medial wall of the vestibule lies in close relation to the fundus and to the facial nerves. Then this is the greater superficial petrosal nerve. As we go down, then this facial nerve, it takes a turn. It takes a turn posteriorly and it becomes a tympanic segment, and it runs along the medial wall of the middle ear cleft. So this is the tympanic segment of the facial nerve we can see here. And we can see both the tympanic segment and the labyrinthine segment in the coronal section. It has a typical snake eye view. Then when the facial nerve, it becomes the vertical segment, it can be seen as a dot posteriorly when we are visualizing the basal turn of the cochlea. So to see the vertical segment of the facial nerve, the coronal view is the best, and we can see the exit through the stylomastoid foramen. Now, to study the cochlea, when we are planning cochlear implant surgeries, we have to study not only the cochlea, we have to study the vestibule, we have to study the vestibular aqueducts, the facial nerves. And so the cochlea, the first glimpse of the cochlea, it is seen usually when we are looking at the ice cream cone appearance of the ossicles in the epitympanum, because these labyrinth, if you see that the semicircular canal, they are encountered quite higher, and the cochlea is located a little bit inferiorly. So this is at the section when we will be able to see the ice cream cone appearance, the cochlea will first come into view. And this is the internal acoustic meatus. Now, this cochlea, as we are going caudally, we can appreciate the turns of the cochlea. We can appreciate the cochlear aperture. We can appreciate the inferior vestibular nerve. Then we are getting another middle and the apical turns of the cochlea. From here, again, it is changing to the basal turn of the cochlea. And one thing to be noted is that the cochlea is the orientation of the cochlea, it is anteriorly and it is laterally. So this one, it demonstrates how the cochlea is rotated anteriorly and laterally. Then coming to the superior semicircular canal, so whenever we are studying, we have to study all the canals, superior semicircular canal, posterior, inferior. So first is the superior semicircular canal, which appears in the cranial most axial sections. This is how it looks. This is the subarcuate canal. The next comes into view is the posterior semicircular canal. So if we have any patients of conductive hearing loss or any patients with a third window syndrome, or if you're suspecting a superior semicircular canal, then we have to reformat the images in another reformatting like postural view, where we can see the bony covering of the semicircular canals. And if there is a cholesteatoma involved, and the most common semicircular canal to be involved is the lateral semicircular canal. So if there is any cholesteatoma, any disease, so it is the lateral semicircular canal which is most likely to be affected. To see whether this is affected or not, we have to see the canal in the coronal section also. So this is the lateral semicircular canal, which appears like a signet ring appearance. And this is the posterior semicircular canal. Then we have to look, whenever we are studying the cochlea, we have to pay attention to the vestibular aqueduct, because in some of the cases of congenital hearing loss, there may be associated enlargement or the dilatation of the vestibular aqueduct. So this vestibular aqueduct we can compare by comparing with the diameter of the nearest canal, that is the posterior semicircular canal. And the last structure which comes into view in relation to the cochlear implantation, it is the cochlear aqueduct in the same orientation as the internal auditory meatus. So this cochlear aqueduct has to also be taken care. So here in the hypotympanum, we can see the eustachian tube and the canal for tensor tympani, and we can see the relation of the eustachian tube with the carotid artery. The vascular structures which are of importance are the jugular fossa, and the jugular fossa, which is a depression in the inferior most or the base of the skull, and the carotid canal, which is formed due to the when the petrous bone is joining the sphenoid bone. And we can see this is the vertical segment and this is the horizontal part of the internal carotid artery. So in the hypotympanum area, we have to pay attention for any bony dehiscence, or if there is any glomus tumor, then we have to pay attention to these vascular structures of importance. So this is one image of a patient with the diverticulum of the right-sided sigmoid sinus. So sometimes the sigmoid sinus, this much anteriorly placed, this has to be taken care, because if it is not noticed while reading the CT scan in the initial part of the surgery itself, it is likely to get damaged and lead to heavy profuse bleeding. So this is how there is a very thin line of bone only. This is the diverticulum of the right sigmoid sinus. Then this is a CT scan showing the soft tissue density in the mastoid, where here we can see there is a soft tissue density of the mastoid. If we see the mastoid air cells, there are no air cells. It appears to be non-pneumatized or sclerotic. Here there is no ossicles which is seen. There is some confusion regarding the involvement of the lateral semicircular canal. So a coronal section was reformatted, and here we can see that there is definitely a bone overlying the lateral and the superior, and there is no dehiscence. Then again, this is a CT image exer section of a patient who presented with the ear discharge and the hearing loss of the right ear for the last 6 months. Then here we can see a pedunculated bony lesion in the external auditory canal. This is the anterior canal wall with the soft tissue density in the median to the lesion. So this was a case, this is the axial and this is the coronal section. So this was a case of exostosis of the right external auditory canal. So I got this picture from one of my friends. So this is a case of Michel's aplasia, which is when the otic placode, when the inner ear, there is a developmental arrest at the very, very early stage, at the 3rd gestational week. So subsequently, there may be other anomalies. If the arrest happens at 4th weeks, 5th weeks, or 6th week, there are different inner ear anomalies which has to be noticed before evaluating the patient of a sensorineural hearing loss. So with this, I come to the end of my presentation, but I would like to share how to see a DICOM file. Anjana ma'am, is it visible?
Yes.
Okay. So we have seen how what are the different structures. There are so many structures in the temporal bone, right from the osteology to the nerves to the muscles and the vascular structures. So what we can do is what we can do every day to for our learning. We can download this. This is a freely available software, that is a Radiant DICOM, where we can view the images in all the sections. So I will be showing how to do that. With this software, we can play with the software. We can zoom in, we can zoom out. We can this is the measurement tool. We can measure the length. We can measure the whatever measurement we want to make. Suppose if you're planning for any surgeries, if there is any very thin bone, we can even measure the thickness. Then we can do the reformatting in all the planes. So this is the axial plane. If I'm placing the cursor here, So this is showing the axial section, and this will show the coronal, and this will show the sagittal. So in this way, we can correlate, because temporal bone, the structures are three-dimensional structures. So we need to see the structures in all the views, axial views, coronal views, and the sagittal views, plus other special views. So I'll just start scrolling. So this is one of the patient. We'll see what are the findings. So I'm looking at the axial section of the patient. Here we can see that now the petrous bone, this was the squamous bone. This is the, let me just, so this is the petrous bone which is coming into view. Here we can see this is the superior semicircular canal, which is the first canal to, first structure to be seen. Superior semicircular canal we can see. Then we can see this is the subarcuate artery. Then this is the glimpse of the posterior semicircular canal. Here we can see the mastoid air cell system. It is a well pneumatized mastoid air cell system, but this bone and this is the sigmoid sinus impression. This is the middle cranial fossa. This is the posterior cranial fossa. As we are going down, we can see that now we can see the 3 dots. Now this internal acoustic meatus is coming into view, and now we are in the superiormost part of the epitympanum. This is the epitympanum. This is the internal acoustic meatus. So let me just zoom in. Sorry. So if we can move our image with this one, and now we can see that the internal acoustic meatus. So we know that the 7 up. So that is the facial nerve. It is antero-superiorly. So this is the facial nerve, labyrinthine segment, and this is the superior vestibular nerve. Now we are going down. We can see the glimpse of the cochlea anteriorly. So anteriorly, we can see the glimpse of the cochlea. This is the typical ice cream cone appearance. This is the head of the malleus, and the cone is formed by the body of the incus. This is the adductus ad antrum. This is the mastoid antrum. This is a well pneumatized mastoid air cavity, and where we can see this is the figure of 8 formation. So this is the cochlea. Now we are coming down. We can see that the cochlea is changing its shape. So my cursor is here. So the cochlea is changing its shape into, so here we can see this is the short process of the incus. So if we try to follow the facial nerve, this is the labyrinthine segment. We can see that this facial nerve is changing its course. It is coming to the medial part of the tympanic cavity. This is the medial part of the tympanic cavity. This is the cochlea. Now we can see now we are about to come in the mesotympanum, where we can see the glimpse of the 3 ossicles. This is the stapes. As we go down, this is the basal turn of the cochlea. We can see the handle of the malleus, the long process of the incus. This is the round window. In the mesotympanum, I'll show the sinus tympani. So this is the stapes footplate. This is the facial nerve. This area is the facial nerve. From the tympanic segment, it has become the vertical segment. This is the sinus tympani area. And as we go down the basal, so we can draw a line along the facial nerve and along the round window, and we can see the orientation of the round window. Now we are going down the ossicles. The ossicles are all good. This is the basal turn of the cochlea. As we are going down, we can see this is the jugular fossa. This is the internal carotid artery. This is the eustachian tube. And we can, if we are planning for mastectomies, we can see the things in the coronal section from anterior to posterior. So let's move anterior to posterior. Here, this is the Prozac space. This is the epitympanum, tegmen tympani. If we go posteriorly, we can so this is the lateral semicircular canal. So if there is any colostoma, we have to see whether there is any erosion of this overlying bone or not. Then we can see this semicircular canal also. This is the promontory, and here there is a faint tympanic membrane also can be seen. So whenever we are studying the CT scan, we have to see the course of all the structures in all the planes. Let me just show you the course of the facial nerve. This one. So this is the facial nerve going. I will just show there is if we wish to see the semicircular canal, if there is a suspicion that if we wish to see the semicircular canal in a different plane, we can orient the cursor. This is a semicircular canal, superior semicircular canal, we can see, and we can so here. So when we are placing the cursor along the short axis of the petrous bone, bisecting the two arms, the anterior and the posterior arm, this view is called the postules view. So in the postural view, we can study nicely the superior semicircular canal, because to study the bone overlying the superior semicircular canal, it is not possible to study in the axial section. So if we are thinking of any superior semicircular canal dehiscence, third window syndrome, or any suspicion, then we can always reformat the images in this postural view, and we can look at the structures nicely. So this is I hope I did a bit justice to the topic. With this, I would like to conclude. Thank you for patient hearing.
Can you stop sharing your slide?
Yes, ma'am. Yes, ma'am. Stop share. Yes, ma'am. Has it stopped, ma'am?
Yes. Now over to Chairperson. Mukherjee sir, can you unmute yourself?
Thank you, Hanifa, for presenting the subject so nicely. I think we are going to the questions, what we get.
Thank you, sir.
There is a question, how the corner septum is formed.
It is the patent suture.
Squamous and the petrous.
Petrous.
That petrosquamous suture persistent, because
Yes,
that
sir.
gives a sort of false sense that is the medial wall. Actually, it is not, unless we go through the corner septum. So we can decide it. If we do CT scan, preoperatively, then we know whether we are going to pay the corner septum or not.
Right, sir. Right, sir.
Then we are going to next is the. Let me go into the other questions.
Can I help you, sir?
Yeah, please.
Where is
Anjana?
the classic position of ampulla of 3 semicircular canals?
Acha.
The ampulla, for that too, I need to show that dissected picture, ma'am. The ampulla of the lateral semicircular canal and the ampulla of the superior semicircular canal, it lies, we can say it lies on the medial surface of
Wall
the
of the epitympanum.
and it is
Yes.
below the facial nerve.
Yes.
And so, and similar to the posterior semicircular canal ampulla, it is also located medial to the vertical segment of the
Vertical segment of the facial nerve, master
facial
segment.
nerve. That's why I've shown that picture, that dissection.
Yeah.
One more question, like why processes cochlear formation is important?
Because of the we
Two
have to
things.
because
Go.
of the muscle, tensor tympani muscle.
No, it actually gives two important factors are there. Number one is the position of the location of the facial nerve, and geniculate ganglion, which lies close to it. So that is again important for that location. So it is always important that we look for that. And moreover, tensor tympani, that is all on that.
I'm happy that PGs are actually answering your questions already in the chat box.
That is good.
That is
a good sign.
Good signs. Anyone want to speak out? You can raise your hand. If you want hands, I will unmute yourself. And then one question is what view is tried for superior semicircular canal dehiscence syndrome?
It is
that is postural view.
Postural view.
Postural view. Postural view is at right angle to the axis of the petrous temporal bone. So
Then,
virtually we know the thickness of the bone which is lying over the canals. So that we can find out the fistula if it is there.
Lot of appreciation from our NEBOI members for your presentation. And, Dr. Gautam Count is asking for exclusively on abnormal findings in the temporal bone. And one more question is
ma'am, that needs a separate class.
Yes, that needs a separate class.
Yeah,
what is the one more question?
Yeah, I would like to just suggest one thing. If you mention along with your presentation the congenital malformation of the mastoids and the temporal bone, I think it will be very much helpful. And what are the clinical presentation for this clinical the congenital malformation? I think if you add these things also, I think it will be a complete surgical anatomy. But what about your?
Ma'am, actually, due to the paucity of this one shortage of time.
I understood. But it is also very important sometimes dehiscence in the facial canal and also absence of coronary septums may lead to some clinical presentation. So we would like to know about what are the clinical presentation due to the congenital malformation, right? So,
yes,
yeah.
And one question.
You might have another class for that.
Yeah, I know.
We'll plan for that again.
That's why we are giving surgical anatomy. We are not giving a detailed anatomy of the temporal bone. That's why it is a surgical anatomy where the surgery is where we need surgery because of some diseases or some malformation, right?
Any comment from Rupam?
Dr. Rupam is there. I could find out finally. So your comment, please.
Can you hear me?
Yeah.
Very nice to hear. Yeah.
First of all, I would like to congratulate Dr. Hanifa. She has given a very, very informative presentation. It's knowing the radiological anatomy of the temporal bone is very much essential, especially when one goes into the surgery. And she has touched every point of this thoroughly. And icing the cake was the diagram presentation. I think if we routinely practice this before every surgery, then learn anatomy from both the surgical perspective as well as from the radiological perspective will be easy. And as Gulati sir has said, the temporal bone is a friend or can be a foe. So by going thoroughly into the subject, both surgical and radiological anatomy and comparing them together, we can friend. So thank you once again for a very splendid presentation. And
thank you, sir.
NEBOI for initiating, starting this great initiative. Congratulations to all. Thank you.
One question in the chat room, importance of subarcuate artery.
Subarcuate artery, yeah.
We can see this one in between the superior, through it passes the some vessel mainly for the neurosurgery.
Subarcuate artery actually it is in relation to the superior semicircular canal. this relationship, because that is important in the sense that when you are doing transleventhal surgery, you have to be careful about that. So you can locate actually.
Okan sir has raised his hand. Okan sir, unmute yourself.
No, I have
And-
unmuted actually. Hanifa is actually, I give her a best of luck before the presentation.
Yes,
And
sir.
she is very much obliged to that and covered everything except the processus cochlearis. I asked that question. Actually, cholesterol cannot erode processus cochlearis.
Right.
Therefore, it
I
is the
forgot.
most
I
important
missed.
line, important
One more
landmark.
thing. Yes, sir. One more thing I missed to show is the foramen spinosum in the
Yes, your
Yes.
for the middle meningeal artery.
Persistent
Persistent
stapedial artery.
your stapedial artery. Correct.
Yeah,
Yes,
very
sir.
correct.
The for near behind the your foramen ovale.
Yes, sir. Yes.
But other side, you are very fine with a very short time. I think
Yeah.
all anomalies you cannot give now.
It is
It's a
not
normal
possible
anatomy
actually.
you can
We
present.
should have a separate class for it.
Yes, separate class for it. Very nice.
One more thing I would like to add, as the processus cochleaformis has come up, it is also called the Piccadilly of the middle ear.
Piccadilly.
Correct.
Yeah, cochleaformis is also called the Piccadilly of the middle ear. That means the king. So it is the last landmark to be destroyed by the cholesteatoma.
Correct.
The question,
Very
yes.
correct.
That I want that for that I asked the question for the question, not for that short impena or you're saying that. That is the as Rupam has answered. That is the main thing. It cannot. It's in Mario Sana's book. You will see nicely written that one. Thank
There
you.
are some questions in the chat box. Rupanjita has asked something. And Rupanjita, can you unmute yourself and you can directly ask the question?
Surgical importance of cog.
Cog, yeah.
Coke. Acha, acha.
It is we find it like this is a bone, fine bone from the superior surface of the epitympanum.
Yes.
Basically, it points towards the facial nerve. So we may get, we may not get. It is not present in all the cases.
I don't think any more questions are there in the chat box.
Yeah.
But still, we have actually it is 9 o'clock exactly 1 hour. But we have taken some time from the academic session for inaugural function. We can have 10 minutes extra time if
let's get
want for discussion. So you all can start your video so that we can take a photograph.
Yes.
Yeah. So
I
I'll
have got
remove
no video.
all
My email is
the
there.
spotlight. If you start your video, we'll take a snapshot.
Yeah, snap. Yeah. Marcelda, please.
No, I cannot. My video is not working. I don't know why.
Okay, your name is sufficient enough.
Okay.
Actually,
Anyway.
now one thing I want to tell here, the cog, surgical importance of cog. Actually, for the antioatic space or supratuberal recess, cog should be delineated to get the antioatic space. Where cholesterol may lie hidden. Therefore, its importance.
yeah, rightly so.
Yes.
Yeah, Bishwajit. You are in the car.
Yeah. Yes, sir. Yes, sir. Sorry, Hanifa, excellent presentation. So yes, sir. As Fukan sir says, COG is also delineate anterior and tympanum and also
Anterior epidemic.
anterior and posterior epitympanic space actually.
Yes.
Along with it, it's also direct the horizontal portion of the fallopian canal.
And
That's
below
the
that is the
excellent
processus cochlearis.
Exactly,
Yes.
sir. Exactly.
Mm.
Exactly. Sir, can I add one point?
Yeah.
If moderators are allowed me.
Mm.
Excellent presentation again, Hanifa. You have shown the DICOM images, but can you get any advantage of your DICOM image? You have a half images. It has
Sir,
some
no,
advantages.
sir. This is from the nearby hospital. What we
Okay.
have requested them to, because ideally we should be seeing both the things together, both the sides. But it is provided from the hospital itself. We are.
Okay.
This is not from our hospital.
That's the thing. Actually, in a DICOM image, both the sides should be there. That
Yes,
way,
sir.
you can compare the both the side. And do
Simultaneously.
you know what is the most important thing is the you see sometimes there's a both the sides, but the alignment is not good. This is the first thing we should do in the software, the alignment. So if you don't get the both the side, you can't do the alignment. You serve there is a kind of inclination towards right or left because of the position of the head during when they go for the CT. So, but that sense, that thing I have learned recently actually how to do alignment in DICOM image. That's the first thing you have to do before starting the DICOM image study, because that way you have a both the side. Suppose it's a petrous apex, both the cochlea, both the semicircular canal, you have to see the same plan.
Yes.
For that, if you are seeing the axial view, then you have to go to either corneal view. Are you getting my point? You have to go to
you get both the things.
Then you align in axial image actually. So that's the things. And another last point I want to add. What I believe in CT study, everybody says DICOM image, but for me, in photography there are two things. One is still photography and there is a motion picture. If you go for DICOM image, that's we are asking for a motion pictures. So that what I want to emphasize here, that when we study the fallopian canal in a DICOM image, that we should not jump from one point to another point. It's not like a one landmark to the end landmark. Study should be so dynamic. Every millimeter you have to study. Then you can appreciate the dehiscence. It is not like it is at the second geno, first geno, some point of the vertical portion, some point of the horizontal. So when you move your DICOM images, every millimeter, that's why you need a good millimeter cut. Suppose when you prescribe for facial dehiscence, in the case of facial palsy, most probably my radiologist, our radiologist know the BSOG is asking for 1 millimeter cut. If they gives a 4 millimeter cut, then we're going to miss the dehiscence portion. Maybe there is some bony speckles are there, which is half millimeter difference. So for dynamic study, that's one thing you have to. Everybody says we have to go through DICOM image, but that should be dynamic DICOM image. If you want to see incas also, see from top to bottom. You flow your cursor, mouse, in a very fluidic way, not to jump from one point to from another point. And for that also you required dense cut. That's from my side. Thank you, sir.
What should be the ideal cut actually? Is it 1 millimeter?
No, Anjanda. That's why, but that's the things. Why you are prescribing CT?
4 millimeter cut.
My pathology will demand why that's why nowadays when we prescribe, then we are prescribing CT and MRI for cochlear implant. That is our protocol. I'm not advising SRCT of mastoid. If I prescribe him a CT scan for CSF rhinoia, this radiologist should know that he is asking for CT scan for CSF rhinoia. So according they know.
Have to direct, na? What millimeter cut you are asking for.
And nowadays most of the radiologists they know actually. They can differentiate also. Suppose in a cribriform area, they may go 1 millimeter, 0.4, 0.6, 0.4, and other area they may can reduce also. Sometimes they can also go for an hybrid these things also.
Yes.
Right.
Therefore, actually, facial nerve is not the friend, but the radiologist should be also a friend of you.
Yes, sir. Yes, sir.
Yeah, very correct.
So, anyone want to share anything?
Can I ask Hanifa one last question?
Yes, sir.
Hanifa, where you get the reference line for that cochlear round window? Sorry. Do you have this a 2-line, no? You have shown 2-line windows.
One is you are asking the reference.
Where you get the reference? Where you get this 2-line? Can you quote the reference?
ये तो मुश्किल है. Long time ago.
I'll try to share it with you. Let's see. Because I will little doubt about this. That 2 reference line, huh? Because since I'm driving, I can't say now. But
Hanifa, you have told one line is along the
round window and second along the annulus.
Annulus.
There's only one paper. That's paper by Nilam Med and Manoj Munikot. It's available in, you can download it also. It's a free download. There is all these all these lines are there in that paper. Just one by Nilam Ma'am, paper by Nilam Ma'am and Manoj.
But this line helps, sir. Like to
I
view
know,
the
I know.
rotation
This
of the
line helps,
cochlea.
but
He helps us
I
to
know
know the
this line
cochlear
helps.
rotation.
I know this line helps, but sorry, since I was driving, that maybe I am confused about the lines. Okay, I'll try the
discuss.
paper.
Yes, sir. Yes, sir. Thank you.
Thank you, sir.
No more participation, then we can conclude it here. Before concluding, I just want, this is my part to offer vote of thanks. First of all, I'd like to thank Professor Gulati sir for his presence, and I'd like to thank President NABOY, Professor Biras Kumar Das, and Secretary Dr. Anjan Kumar Bhuya for having this idea of starting the NABOY classroom again. And I would like to thank Professor Sagata Khanna ma'am, because she was during the COVID time, she was the pioneer in starting the NABOY classroom. And I'd like to thank Dr. Biswajit Gogoi. He was the first one to start the NABOY classroom in NABOY history. I exactly don't remember the under whose presidency, but thank you, Biswa, and helping us in this in this NABOY classroom. I'd like to thank Dr. Rohan Malla, who is the webmaster for NABOY. And I'd like to thank Dr. Hanifa for your wonderful presentation, and also thank Dr. S.N. Mukherjee and Dr. Rupam Bargohai for your active participation. Finally, I'd like to thank all the members for your presence. We had 70 members at one point of time, and for your presence and being on time. And thank you, everyone. And I'd also like to thank the PGTs for joining this classroom. And we'll be continuing in this classroom in every second and fourth Thursday. So from 8 to 9, be there. And those who have attended this NABOY classroom, we have arranged for a participation certificate. It is there in the chat room. You can download it, and then you can have it. And with this, I conclude this NABOY classroom. Thank you, everyone. Thank you.
Thank you very much.
Thank you very much.
Thank you,
very much.
Anjana, and congratulations too.
Thank you very much. Thank you very much, and very
Thank you.
good night.
Thank you. Good night.
Rohan, you can